Thank you, Chairs. Thank you, Dr. Batra. And thank you, the organizers. As we are moving into the fag end, these two abstracts will focus on the patients who are in the fag end of their lifespan, whether because of the age there should be any differentiation their cancer treatment or not, and that's what this Canadian organization did to find out whether the age really makes a difference in deciding the treatment, and that decides the outcome of the patient. So this is the first abstract, real world practice patterns, treatment related toxicity and survival outcomes in older patients with metastatic RCC, and results are from the Canadian Kidney Cancer Information System, a very well preserved system which is taking all the things into the accounts. So background is, as I said, there is a paucity of data with respect to optimal management of metastatic RCC in older patients. Real world data may help close this knowledge gap and improve care for older patients with mRCC, where we are usually conservative offering them the treatment. Now, this was a retrospective assessment. The data was collected from their central Canadian Kidney Cancer Information System. They identified all the patients who got diagnosed with mRCC and categorized them as either older, defined as age more than equal to 75 years. Although, as such, aging is a continuous process. They put on a quantum of 75 years. More than that is equal to age at, and younger less than 75. They compared the first line mRCC management strategies and treatment related toxicity. The secondary outcomes were overall survival and time to treatment discontinuation. So standard methods, chi-square stress and Fox proportional hazard ratio were reported by age, adjusting because the treatment of the kidney cancer evolved over time with the incorporation of the different TKIs as well as the ICIs and combination. So they adjusted that, and based on the IMDC risk group histology, Carrison comorbidity index for overall survival and time till discontinuation, and then reported that. So impressively, about 2,576 patients exactly were included, of which 2,203 were less than 75 years and 373 were more than 75 years. So almost about 1/5 of the patients were old as per their definition of the old age. Baseline demographics were comparable, although with the age, the comorbidities were higher, with 5+ comorbidities in 95% patient versus 60%, 67% in the elderly group. And more commonly, the KPS score was less than 70% in 18 versus 13%. So 18% in aged more than 75 had a KPS per 70% less than 70 versus 13 in the less than 75 years of age. Older patients, they underwent metastatic less frequently, and that's usually the more conservative way of treating such patients. 15 versus 25%, significant p-value of 0.0001, and were less likely to be enrolled in clinical trials. Most of the clinical trials have a cutoff of 70 years or less, some less than 75, only 1 or 2 trials less than 80 years of age. Older patients receive first-line TKIs more frequently, that is a single agent, then immune checkpoint inhibitors because of the perceived toxicities of immune checkpoint inhibitors in this age group, even when adjusted by year to account for changes in the practice patterns. Almost all patients at TKI monotherapy most frequently prescribed was sunitinib. So that's fair because sunitinib was there before the other TKIs came in. So most of the patients will be on the sunitinib. Although older patients were more likely to receive pazopanib, and that's more from the real world evidence of sunitinib equal to pazopanib. At some point of time, we always discussed and debated way back in 2010, 11, 12. So the results were, amongst all patients who received first-line ICI-based treatment, there was no difference in the type of ICI regimen, that is doublet ICI versus ICI plus. So if the performance status was same, less than 70 versus more than 70, less than 75 versus more than 75, almost equal patients received the double ICI. Older patients did not experience more frequent treatment-related toxicities with ICI-based treatment. They did, however, experience more grade 3+ toxicity with TKI monotherapy. Older patients had shorter OS even when controlling for IMDC score, because it's understandable because most of them received only TKIs, not the ICIs. And there was no difference in the time to discontinuation by the group. So they concluded that patients more than 75 years of age received TKI monotherapy more frequently than those less than 75 years of age. And that also is reflected in the Indian practices as well. Though when they received the ICI-based regimen, they did not experience more treatment-related toxicity. So this should give conviction to us that age is just a number. If the patient is fit, KPS is okay, there are not much comorbidities, they should be treated as per the guidelines, not taking the age number itself into the consideration. So they concluded that clinicians should individualize treatments for older patients not solely based on age, but after discussion of all available options in a patient-centered manner, considering comorbids, disease burden, and patient preferences. Now, second abstract is also in the RCC. Now it is IO-IO combination, which is usually dreaded even in the younger patients with the overlapping toxicities. Now, in the elderly population and with the poor performance status, whether the Ipi-Nivo combination was showing any different toxicities, decreased outcomes that they found out in the real world basis. So, because Ipi-Nivo improved overall survival that we saw in the Checkmate 214 trial with the intermediate and poor risk, and it is the category 1 recommendation for these group of patients. A subgroup analysis showed no significant difference in OS for Ipi-Nivo in patients 65 to 75 years old, as well as patients more than 75. But even if you ask me today, a patient who is more than 75, I would think twice or maybe thrice before suggesting a combination of Ipi and Nivo. So they evaluated the efficacy and toxicity in older and fairer population in a real world. Methods, again, they collected the data from the Canadian Kidney Cancer Information System from January 2011 to March 22. Probably 2015 to 22 would have been the period when the IOs were picking in, ICIs were picking in. Median follow-up was 14.3 months. A comparison was made between outcomes and toxicity in patients. Now, this is very confusing. Greater than equal to versus less than 70 years old. Greater than equal to versus less than 75 years old. KPS less than or more than equal to 70, and greater than equal to 70-year with KPS less than 70 versus 70-year-old with KPS more than 70. Too many variables, but their age cutoff was, and the KPS cutoff was 70. So toxicity graded was as per the standard CKCis. The found out the OS, the progression-free survival and time to treatment failure by the standard statistical methods, and the results they found was median overall survival was worse in older patients at 30 months in patients greater than or equal to 70 years versus 45.4 months in patient less than 70, and 19 months in the patient more than 75 versus 45.5 months in patients less than 70, despite similar disease control rate and toxicity. So this, based on this result, I would assume that patients who are younger, less than 70, or for that matter, less than 75, have a better chance to survive with the Ipi and Nivo combination as compared to the older ones. Median PFS was similar in younger and older patients. So despite median PFS being similar, the median OS was worse in the older populations as compared to younger. Median time to failure was comparable in younger, in less than 70 versus more than 70, less than 75 versus more than 75. And median OS, PFS, and TTF are comparable in patients who were demarcated based on the KPS. So adjusted and unadjusted analysis showed no difference in OS and PFS between the groups. So OS, this I think I've gone back. So they concluded that use of Ipi-Nivo in metastatic RCC in older patients was associated with inferior OS, while decreased performance rated had equivalent OS. Both groups had equivalent time to failure and progressive disease without higher toxicity. We believe that Ipi-Nivo is a reasonable treatment option for older and low performance status. So my although their conclusion was favoring that age is just a number and it should not be the only deciding factor. But if I go by the first result, median OS was worse in the older patients at 30 months versus patients in more than 70 years of age. This makes me believe that Ipi-Nivo still is a choice which should be used only when you pressed against the wall to use that thing. Otherwise, if I go by the real world evidence, they showed that there is no difference as far as age is concerned. So this is the trial: less than 70, more than 70, less than 75, more than 75, KPS less than 70 versus more than 70. As per the trial and the hazard ratio, they showed that they were almost similar. There was no difference, but I will still, in a real world life, will be very skeptical of using Ipi-Nivo in more than 75 years of age, if not more than 70 years of age. Thank you. Thanks for your patience. Thank you, Chair.
Thank you, organizers, and we'll